Hello and welcome to the fourth episode of BTW Bellabeat Talks Wellness podcast. Today we'll be talking about fertility health, PCOS, Nutrigenomics, and the future of fertility health in women with our wonderful guest, Dr. Tracy Malone. Dr. Tracy Malone is a naturopathic doctor, co-founder of Conceive Health, mom of three who also struggled with PCOS, polycystic ovarian syndrome, while building her own family. Dr. Tracy merges conventional medical treatments with natural preventative approaches to treating infertility. She advocates for her patients to address their own metabolism and has a special interest in nutrigenomics. This is the study of how a person's genes and diet interact. She is also the director and nutraceuticals at Bird and Bee and helped to formulate their preconception and pregnancy supplements based on nearly 2 decades of clinical experience. She has taken a special interest in the preconception period and influence of genetics in fertility patients, and has worked to create the ultimate support via supplements for males and females during the preconception period. Through her 15 years of experience supporting fertility patients in clinic, Dr. Tracy knows how optimized egg and sperm health can improve clinical success rates, reduce complications, and create a healthier pregnancy. With a unique understanding of the trials of trying, Dr. Tracy focuses on making sure each person's journey is comprehensive, compassionate, and convenient. Welcome, Dr. Tracy.
Well, thank you so much, Urška, for having me. I'm delighted to be here. I fully, get behind women having specialized healthcare. We are complicated pieces of machinery, and so I think that often there's, more comprehensive care available than what might meet the eye in mainstream medicine. So, as you mentioned, I am a naturopathic doctor. My clinical care focus is on infertility and reproductive medicine. My clinical practice I co-founded along with Dr. Jennifer Fitzgerald 12 years ago. And we are the first preconception clinic that is located inside a conventional IVF center in North America. So what we do at Conceive Health, that's the name of our clinic, we would see patients, couples or singles that are thinking about fertility, trying to conceive. I also see a lot of women that would have endocrinology disruptions or hormonal imbalances that would cause certain pathologies like PCOS or endometriosis. So anything sort of reproductive endocrinology wise, we would see in the clinic. And then if we're getting a bit more specific, our patients that are trying to actively conceive, or maybe our patients that are actively going through fertility treatment, there's a lot of lifestyle levers and metabolic factors that we can influence through lifestyle augmentation, circadian patterning, clinical nutrition, supplementation, knowing your genetic fingerprint, that we can help to sort of amplify and optimize the metabolic signature, if you will, of that given patient prior to conception. So, all females are born with all the eggs we'll ever have, right? And so the time to really optimize that egg health and gestational environment is 3 to 6 months prior to conception. So that's why my clinic is called a preconception clinic. And that preconception window lies 3 to 6 months prior to egg meeting sperm and implanting into the uterus. So your real opportunity for change in those factors comes actually prior to pregnancy. So in that sense, I would consider myself a truly preventative doctor. And we do preventative lifestyle medicine directed at preconception fertility in a clinical IVF setting for patients doing ART. So that's a little bit about me.
Awesome.
So my clinic.
And your special field of interest is actually nutrigenomics, right? Could you explain a little bit what that is, what it means?
Yeah, so nutrigenomics is I would say a relatively new field that has been emerging over the past 10 to 15 years. And nutrigenomics, basically, when we know your fingerprint, so if we do, say, a saliva test and we can map your genes,
Okay.
there are certain genes within your DNA strands that will absolutely influence your ability to metabolize certain nutrients into their usable form.
Mm-hmm.
There are certain genes that would influence your vulnerability to a lot of metabolic factors, inflammation, insulin resistance, testosterone or estrogen dominance, your capacity to detoxify, both pharmaceuticals and metabolic stress factors. So if we can understand and have a bit of insight into your fingerprint, and by a fingerprint, I mean your genes, then we can tailor your treatment for you, and we can, further optimize our recommendations to you, right? Otherwise, we're making recommendations for the GWA, the general wide population associations.
Right. Incredible.
Right?
So
yeah.
You kind of look at that in the frame of fertility in women, but would you also recommend other women who are not maybe focused on their fertility right now, but are looking into other aspects of their health and wellness to also go through this kind of, it's not like, I guess it's not just treatment per se, but it's also kind of exploration or...
Yeah, it's knowledge, right?
Knowledge, yeah.
Your genes are your genes. So you're born with your set, and your genes don't
Right.
change. But when you change the environment, you can change how the genes function. So first of all, I would go back to say, should females do it? Yeah, it's a very interesting sort of lens and insight. We have I would estimate we might even have more insight on male factor fertility through nutrigenomics than we do on
as
female.
in all fields of health and wellness, right?
Yeah.
Unfortunately.
So, they would say a semen analysis is like a microscopic insight into the man's overall health. And so sometimes if genes and environment are not really complementary to one another, you can see pathology evolve, right?
Right.
And so yeah, I think there's a good amount of insight, not only for fertility patients. I think it's super important to remember that 50% of the patients that are in a fertility clinic don't have a diagnosis. It is idiopathic subfertility or increased time to conception, meaning lots of your tests are normal. We don't know why. So that would be a recommendation probably for an insight into a nutrigenomic panel for me. You could say the same thing about females and males who are experiencing signs and symptoms of reproductive pathology, like PCOS, right? She's got irregular cycles. She's got irregular ovulatory patterning. Maybe she has acne and obesity or hair loss. All of those sort of factors are symptoms of an underlying hormonal pathology that likely would be displayed in your genes. Yeah. So although you would only do this type of testing once, you might look at it through different lenses in your lifetime, right? Sometimes it's about improving her day-to-day health and psychoregularity, PMS, pain, etc. Sometimes it's about regulating ovulation so she can get pregnant. Sometimes it's about regulating her insulin levels so she doesn't produce too much testosterone. So you can use these levers, I think, to treat her along her reproductive career, I would call it. So yeah.
I mean, just mentioning reproductive career in women, let's say, how come that so many women, especially today, observe irregularities in cycle, such as PCOS, endometriosis, other disruptions in their cycle, but they only kind of go about treating those issues when they try to conceive. And often by that time, it's already kind of complicated. I guess with your experience with patients, like why are we so why is there so much adversity towards treating ourselves before we have to do something with our cycle, I guess?
That's a great question. It's a great question. And, I used to teach at the college for the naturopaths, and I used to be a clinical supervisor there. And my interns that would be in their fourth year getting ready to graduate, doing their clinical rotations, my hope would be that I had trained them in a way to spy these early diagnostic flags, red flags, and do something about them early, right? Let her know in her 20s that you suspect that there might be a bit of a pathology here, because if she knows, she will probably do something about it,
Right.
and if she chooses to take one treatment method over another, at least she's informed, right?
Right.
What I do see a lot of times is an acute care system treating symptoms, pain, acne, irregularity of cycles with, pharmaceutical approaches that mute the symptom. And that it often does take care of a lot of the pathology at that time, sometimes for years, right? If she takes an oral contraceptive, she's going to get a regular cycle.
Right.
But if she takes the oral contraceptive away, she's still got irregular cycles if she's
Right.
actually trying to ovulate on her own. So it's a great question. And so I would answer that it's like very multifaceted, very. If we're separating PCOS and endometriosis, let's say, PCOS, a lot of women get put on early for early signs of androgen dominance, acne, pain, hair growth, those types of things that maybe a young adolescent female can't manage very well, right? Who's growing up. And then, but she's not using it for contraception. So when I do an intake and she says, oh, I've been on the pill for 10 years, I ask her, why did you go on in the first place? Like, did you go on because you had repetitive cysts? Did you go on for contraception? Did you go on for skincare? Like what, why? Tell me why.
Yeah.
And that can really give me a lot of information, right? Endometriosis, for example, can be a bit more elusive to diagnose because the gold standard is laparoscopic surgery to diagnose. And in my opinion, that's a huge barrier to appropriate care. Right? So they would say on average, it takes an endometriosis patient 8 years to be diagnosed, which is insane. Wow. And I think it's because the symptom set of that particular pathology is very variable depending on the patient and the severity. And the only true gold standard diagnostic is a minor surgery, which they don't really see it as acute care medicine. So she'll be waitlisted, and who wants to have surgery if it's maybe not it. But without the diagnosis, she's not properly managed, and it will affect her fertility. Right? So,
interesting.
Yeah, tricky, right? Yeah.
So several layers, you would say.
There's
also
many layers to it, many layers to it, right? And so you're not wrong that we could be better at identifying early, diagnosing early what we are dealing with. And I think the second component to that would be educating the patient on what does that mean? What does that mean? What can you do now? Or what are my treatment options now that might help to resolve this? Right.
But I guess from the user perspective, or just a woman's perspective, I see that we are progressive in the education side. There's more and more talk about PCOS, endometriosis, issues that concern our reproductive cycle. Maybe even to the point where it seems that it's, there's more and more of those issues. Is this kind of like a modern problem? Are there more endocrine disruptors in our, environment, food that might be causing this? Or it has always been like that, but women have gone undiagnosed basically their whole lives?
I think it's both. I think it's both. I think I would silo this into three things.
Mm-hmm.
Is it happening more now than ever? Maybe. Yeah, maybe. I think. Are we better at diagnosing things now? Yeah, for sure.
Also,
Are we having babies in our 30s when we used to be having babies in our teens and
right.
20s? We are, right?
Guilty of that as well.
So there's a ton of factors here, I think. Um, and then you look at our, modern day lifestyle, and it cannot be lost on us that, sometimes in certain demographics, over 50% of the population is obese and eats an incredibly processed diet and has a sedentary lifestyle, and their circadian patterning is very disarrayed. Those are real factors and they're modifiable. That's the first thing we go after in clinic because it's like the obvious, right?
The
And
lifestyle change first.
totally. Well,
Mm-hmm.
and this is, we're talking about PCOS today, and so if a young teen was diagnosed properly with PCOS before she was put on the pill,
Right.
and she was told, well, you have an increased vulnerability to insulin resistance and obesity if you don't eat enough protein and exercise.
Mm-hmm.
With just a tiny bit of weight loss, you can normalize. Oftentimes, you can normalize your cycle, if that's the type of PCO she's
Right.
representing. It doesn't work in every case, but it doesn't hurt either, and
Mm-hmm.
oftentimes it can normalize the case.
Right.
So, but I don't think she's offered those early enough, right? And
Yeah.
then it becomes incredibly pathological later on in life. And then they start treating it with acute care medicine like metformin without exercise and all of this kind of stuff, right?
Right.
Yeah.
And you yourself mentioned in your bio that you suffered from PCOS when building your own family. Has that experience also influenced your professional path? Like, what insight did that offer to you going forward as physician and treating other patients?
I would say tons because, well, first of all, I don't think I even knew that I had PCOS until I was working in the fertility clinic, right? And
Oh,
so I
wow.
got a fertility assessment and said, wow, this is kind of all over the place. Um, why? Because, I don't mind using my personal case, because of irregular cycles, I was put on the pill early, right? In my mid-teens. And I went to school and maybe that became contraception protection too. And so then in my late teens and 20s, when I was in post-secondary education and medical
Mhm.
school, I stayed on it. And then only, did I clue in, hey, I've been on this for 10 years and I haven't ovulated in 10 years. That's strange to me now, now that I know how it all works. And so after coming off, yeah, sometimes yes, people drop right back into a cycle and it normalizes right away. And then some people, it can take months to years, right, to get a regular cycle back. And oftentimes it comes with hormonal patterning that's so confusing and can cause mood and skin and weight changes. And so I guess I just became really dialed into the metabolic representation of those types of factors in a young woman and how confusing that would be if you didn't have medical training, like specialty medical training. And then now, fast forward to being in the clinic, these women are, Kirby or cuspy PCO, polycystic ovary, or blatant polycystic ovarian syndrome, two different sort of classifications, I would call it. And a lot of them don't even know,
Right.
right? And so I said, oh, did you know this? And, ensuring that you maintain a certain level of muscle mass and keeping your insulin low. And all of these things can affect your ovulatory regulation and really dampen your symptomology. No
Right.
clue, right? And once you explain it to her, that's, context changes your choices. You give her context, she's going
Yeah.
to change her choices, right? And then her doctor is not running around asking her to eat healthy food. She's eating healthy food because she knows it's going to regulate her hormones. She feels better. It's, that's liberating stuff.
Amazing. So
Yeah.
that kind of opens the fertility window that you mentioned before, kind of like 6 months prior to trying to conceive, to basically from our teenage years to, whenever we're trying to conceive. Is that
Mm-hmm.
correct?
Yeah, from, definitely in your early 20s, you want to kind of consider, and I think that's been sort of lost in the public messaging, right?
Right.
Our average age of first-time moms in the 2020s is, 30, 31 plus. And
Yeah.
so we're literally a decade older than our, previous generations in starting our families. And that certainly comes with both hormonal, hormonal and, egg quality, considerations. Okay. If she's not even trying to have a baby until she's 35, then I'm going to recommend probably different agents for her than I would for someone who's trying in their 20s, right? Because her egg quantity is already on the decline.
Right. So it's not just egg quantity, it's also egg quality, which is
right. Yeah. And I think that's where my whole clinical practice is based off of egg quality versus quantity. So quality matters, right? And because it's the dominant eggs that ovulate. It's the most vital follicles that fertilize and make it to a blastocyst, and it's the ones that have good genetics that come through for a healthy live pregnancy. And so your opportunity to influence that is front loading it 3 to 6 months before you start.
right.
And so the idea with Bird and Bee specifically was twofold. Make the testing more accessible to him and her at home, so they can understand if there's anything pathological going on early. Because half the time, the wait or the fear of getting into the clinic. So the mantra of fertility at home is really to create at-home diagnostics so that they can be flagged early if they need to be in the clinic earlier than they think.
Right.
It's always a timeline in the reproductive field, and then subsequent to that, if they are filtered to the clinic or they are choosing to start their family just a little bit later, then there's a plethora of agents and factors that we can use to elevate their egg quality, sperm quality before they start. And so that's kind of where this all came from.
Awesome. So, but what kind of things can we do ourselves to better sperm quality or egg quality, apart from the obvious eating healthy, be young? And what is also that age frame in which women have the best egg quality?
Okay, so let's rewind. So let's go your last question first. So it typically, because sometimes you will see younger women with diminished ovarian reserve or premature ovarian failure, and so those women would be in a different category, and that does happen. But if it's your standard, 20-something, the presumption is that her egg quantity and quality is best in her sort of, early to late 20s, right?
Right.
Quantity and quality. Once she clips over 30, you'll start to see, that's when we'll start to decline in reserve. Again, it can be variable. You can start to see that decline earlier. And that's why we flag those patients and say, just because you're 20 doesn't mean, it's not possible. Just flag yourself if that's what's actually happening. And you can do that with a simple at-home or serum FSH test. If it's ever above 10, go see your doctor. Right? Because women in her reproductive age should not have an FSH above a 10, really ever, unless there's something going on. So it's a simple test, right? And then when you're moving into your 30s, they would say it starts to decline at 30s. We're going to start to see a sharp decline after 35. Okay. And then year after year after 35, we would say her fertility potential is halved, right? Until
Oh,
by the time she gets 40, 42 years old, the probability of having a spontaneous conception with a healthy live birth is less than 5%.
right.
Right. And so the messaging that we see in front of us in the media is different than the
Yeah.
biological reality. And I think that is a message that we need to, again, context changes choices. If she knows that her reserve is declining early in her 20s, she has the option to egg freeze. She has the option to, put eggs on cryopreservation reserve if she's not ready.
Does
She
that,
has
sorry, does that diminish the quality of the egg, or it doesn't influence it at all?
doesn't influence it at all,
Okay.
because that particular cohort would have been
Mhm.
utilized in that cycle anyway.
Okay. Interesting.
Yeah, so that's a myth busted, right? A
Awesome.
retrieval or a cryopreservation cycle, also known as an egg freezing cycle. If you do even multiple retrievals to bank eggs or embryos, it does not affect your overall egg count, because those follicles would have been utilized in that cycle anyway.
Okay. Interesting.
Yeah, yeah, yeah. And then just to turn the table a little bit for males, because the
Mhm.
number one reason why folks did IVF in Canada in 2022 was male factor, fertility.
Right. Yeah. Why do we always talk about women when it comes to fertility and focus kind of like on our um,
Totally. Yeah. And
cycle and
yeah, I agree. And I would say almost every single woman that walks through a fertility clinic would agree with that statement.
yeah.
And so, we're quickly recognizing that we always knew that, sperm's half the DNA of the baby, but the
Mhm.
sperm health and the sperm quality and vitality, count and motility, DNA fragmentation, all of these factors will dramatically impact the health of the embryo and the baby created from that fertilization. And the cool piece of information that I think a lot of people don't recognize is that, unlike women or unlike females, men turn over their entire sperm count every 80 days.
Hmm.
So men make their sperm in the present environment, okay? And every, 3 months, we get a whole new swim team. Right?
Right.
Whole new swim team once a quarter. And so I say, don't worry too much. We can make some changes and we
Right.
can see who's trying out next quarter.
But it's also
Right?
getting worse and worse, right, with age, each cohort, each set.
Um, there are definitely age-related factors with sperm over the age of 40,
Mm-hmm.
but the bank of and quantity, typically no. I would say
Okay.
no, that's pretty stable for him, even up into his 50s sometimes, as long as he has normal testosterone levels and he's fit and stuff.
Okay.
But they can have higher DNA fragmentation, which is a
Uh,
test that we do that shows, wear and tear on the sperm DNA helix, and that would
mhm.
influence the sperm quality issue. But also we can treat that with antioxidants, right? And lifestyle factors often.
Okay. Interesting.
Yeah.
And what are some of the common health issues in babies of conceived by older parents if they don't go about treating their egg and sperm quality?
Well, I think that as a blanket statement, I would say you see more genetic issues
Mm-hmm.
with across the board, and there's a variety of different genetic issues. But you see more genetic issues with babies born from older eggs and sperm, right? And by older, I would say over 40 for sure. And so that's kind of a fact of biology, right? And And so you can also see an increased risk in pregnancy loss in women over the age of 40. And this would be a combination factor of both potentially more genetic anomalies in the baby being carried. And second to that, her metabolism, vascular system can be older, right? So she's more at risk for preeclampsia and hypertension and diabetes in her pregnancy.
Mm-hmm.
Yeah.
Apart from testing, is can we see anything about the egg quality, not just the quantity, from the female natural cycle? And are there any phases of the cycle where we can detect symptoms that might be tied to egg quality?
It's a great question. So, yeah, there's a lot of symptoms that can be, pain, I would say. That's like the number one alarm bell, is that if she's in like 7 out of 10 or more pain every month, we want to know about that. Like, how come? And so there's a variety of different reasons for that. But yeah, we would want to definitely address pain factors, because that sort of infers that there's a inflammatory cascade of some type going on somewhere, or cysts or something like that. If she's got wildly irregular ovulatory patterns, or she's missing cycles and only having a period, we would definitely want to treat that, because we can affect that with both preventative medicine and with, mainstream medicine. I would say the factors that we can most heavily influence by prevention and lifestyle factors. Of course, clinical nutrition is a massive, lever to pull. I think we have extremely skewed views on what a healthy diet is today.
Okay, interesting.
There's so much information out there. And so, for example, I saw 3 or 4 new patients in one day last week. One was keto, one was vegan, and one was completely paleo, right? And so each one of these dietary practices would have massive influences on her egg quality, right? So the ketogenic person, if she's not eating the right fat, can put a ton of oxidative stress onto her mitochondria. The vegan patient, maybe she has a really low protein diet, essential fatty acids and low vitamin A and B12, all factors for egg quality. The paleo patient, I would say paleo is probably your best, right? It's a very unprocessed Mediterranean diet. And paleo in the loose sense is just moving away from processed foods and grains and things like that. And I think people do better on a balance of animal protein and vegetable plant-based carbohydrate. Yeah.
Interesting that you said that, especially in connection with also, so I guess this is the result of marketing that is out there. I guess women are often marketed wellness trends that are not very well researched, or especially are not researched for women. So the effect of those trends on women's health and our reproductive health and so forth, but also the reality of our biology, like you said, with going, our egg count and quality declining with age. But then what would your recommendation be for nutrition, apart from staying away from trends that are not very well researched? What is then the best nutrition?
Well, that as a blanket statement, I would say nothing extreme, as the first lead in. And it really depends on where the patient is starting, right? Mm-hmm. And so, I see patients that have very low BMIs, body mass index below 18, and they're wondering why they have irregular cycles. Maybe your reserves are low and we're under consuming in certain things. Then I have patients that have a really high BMI, so body mass index above 30, right? Meaning that she is five BMI points over normal weight. Likely she's carrying excess body fat or adipose tissue. And fat tissue, if you allow your muscle mass to degrade and your fat tissue to build, it affects how you process your hormones. And so, the simple factor of if she's got a high body fat, then we're going to target lean muscle mass building, right? Through strength training and a higher protein diet, all of those things that will help her become more insulin sensitive and regulate her ovulation. Versus the patient that has the low BMI, I really loosen the reins for her. In a sense, I just want calories in, as you know, and ideally they come from unprocessed. And I would probably have her exercise too, but to pique her appetite, not to build muscle necessarily. Okay.
Right.
Yeah. So different strokes for different folks, but the underlying, you know, in my opinion, the healthiest is probably a pesco ovo lacto vegetarian. Like, so you're primarily plant-based from your carbohydrate intake. So beans and legumes, root vegetables, garden vegetables, and some fruit. And then you get your protein sources from plants also, but then also from eggs, dairy, and seafood, fish, right? It's you know, there's research showing that if a couple eats fish 2 times a week or more, they have a shorter time to conception and higher ongoing pregnancy rate than people who eat the same amount of animal protein from a different source. So what does that tell us? It's interesting, right? Because the amino acid structure is very similar, but what's different is the fat spectrum.
Okay? Yeah, interesting. And it's also very similar to results of research in longevity and you know, people living longer on this kind of diet, kind of like a expanded Mediterranean diet, I would say.
Exactly. Yeah, exactly. So I think, you know, what's old is now new again.
Yeah.
But you know, and I think there's real value too in when you eat. When you eat, in my opinion, is just as important as how much you eat. Sometimes.
Oh, interesting. What do you mean by that?
Yeah, so I would say that every cell in our body has a clock, right?
Mm-hmm.
Even our hormonal cells and our fat cells, and so our generation has real sleep problems. We don't get really well rested sleep. Sometimes even if we're sleeping for the right amount of hours, we're not getting a deep REM restorative sleep.
Yeah.
And in part, I think it's, you know, these guys and people are scrolling, we're online all the time, and the artificial light has a massive impact on our circadian cycling.
Incredible. We just talked about this on our last episode with Dr. Smita Patel, and you're just saying exactly the same things.
So incredibly important. I couldn't overemphasize it. When I start with my patients, when I go through the lifestyle check boxes, I always would say sleep is the best antioxidant on the market. So start there first. And then gentle reminder, like we make 80% of our hormones when we sleep. So if you're not sleeping, we're not repairing very well, and we're not reaching sort of our hormone optimal potential, if you will. And I think that's lost on this generation a bit, right? And so your best sleep hours, they would say, is between 10 p.m. and 2 a.m. So if you're not sleeping during that time, you're missing the REM boat, so to speak.
Right.
Yeah.
Sorry.
So just going back to the original question is like, why is that important in relationship to when you eat? Mm-hmm. Your last meal should really be at least 3 hours before you go to sleep, right? And so that's why I try to get my patients to pick a hard line time in the evening that's reasonable for their job, to have their last meal, and kind of stick to that, right? Because your body loves routine, right? And so if you can curb your last meal by 6:37 p.m. and then go for a walk, I call it the siesta stroll, it can drop your insulin nicely and you just get a deeper, more restful, recovered sleep. It's good for your glucose stability as well. Yeah.
Interesting. And then in the morning, when do we start eating? Like how short or how long should that fast be?
Yeah.
Between 7.
So, you know, in an ideal world, I would say a solid 12 is good at 14 hours you start to see real movement in some of the popular fasting mechanisms. And so it doesn't have to be this. This is the other trend I see, is this
Yeah,
very
intermittent.
strict intermittent fasting windows. And so, recognize that reproduction is, is a growth phase, right? And so you can use intermittent fasting to trigger catabolism or anabolism. So growth phase is what we want to go into. And so if she's too restrictive, she'll not feel well, and she won't have a robust of a, hormonal response and stress response. So I always would say that a good night's sleep starts in the morning. And so if you want to really solidify your sleep and wake time. They would say that if you move your bedtime or your wake time more than 60 minutes off of its center, you're going to affect hormones that influence your hunger levels for like up to 48 hours afterwards. So you go to bed one night, 1 hour too late, you're going to be 30% hungrier for the next 2 days and have to fight your willpower. Right? So if you can stick to the same routines, your body likes that. So if you can get up in the morning, I would suggest dumping at least a half a liter to a liter of lemon water or water with an electrolyte in first thing in the morning. And then you want to try to expose yourself to natural light with no sunglasses on, right? For 15 or 20 minutes. And it just lights up your circadian, entry pathway and sends off a sprinkler of hormones that says it's on, right?
Awesome.
The day has started.
Is this where the other trend comes from? The sun gazing? Is that another? They're all kind of based in some truth, I guess.
I think it used to be just called farming, but now we call it like forest bathing and sun gazing or whatever. But yeah, you can't really get that same effect without allowing the full sun spectrum rays hit the back of your retina. You don't have to stare into the sun, but just be in the natural sunlight without sunnies on. And then conversely, at nighttime, I've gotten into the practice of getting people to pick a time that they come off their devices, off the televisions and off the screens for work, off the phones, and actually turn out all the artificial lights in their house, right? Like dim it right down so you go into the darkness with the sun. And it can be a super powerful tool. If you've practiced those things, you don't have to use as many sleep aids. Right? And I'm into that because I want you to make your own melatonin, right? And I want you to fall asleep naturally because you're going to get a better sleep.
Right. Can those helpers also disrupt our endocrine system if we abuse them, or is there no correlation?
No, I would definitely say if we like overdose melatonin, there's a percentage of the population that would have, feel groggy in the morning and not be able to process that much. Recognize we release pulsatile doses of these hormones, right? In small incremental amounts. Whereas when you're trying to dose them, people give them in a bolus dose all at once, right? And kind of can desensitize the receptor. Yeah.
Okay, interesting.
So yeah, if I can, I want to try to get him or her to sleep on their own. Maybe I'll use things like magnesium or L-theanine or valerian. But I try not to do a ton of straight up replacement if I can help it, unless I need to. If I need to, I'll use it.
Okay, interesting. And so you talked about kind of adjusting our nutrition and sleep to circadian rhythm, but do you also see benefits in women adjusting their nutrition and also, I guess, sleep to our menstrual cycle? So kind of like adjust it by phases, eat more protein in luteal, I don't know.
Yeah. And so, what I think, and this is where sometimes we can't always get it done through food alone, right? We're busy folks these days, and there's very few people that are going to radically change their lives and slow down their lifestyle when they're in the peak of their busy,
Yeah.
And so this is where supplements are truly supplemental to a healthy lifestyle. Like I would always say food and sleep first, but also, there are certain nutrients that can get quite depleted in a modern day lifestyle. And then if we're trying to proactively preserve egg quality and egg health and sperm quality, I usually recommend that my patients in their reproductive age would take a prenatal vitamin as their multi, right? And I think this is so valuable because by doing that, you would, sort of unconsciously supplement some of the nutrients that would be potentially depleted by oral contraceptives and other, utilized pharmaceuticals in that age, like B6 and folate and zinc, to name a few. And so she's going to feel better if she has those replaced. If she's not on the pill and she has like an organic menstrual cycle, you keep coming back to, can we tell the health of the cycle and the oocyte by anything within the cycle in the follicular phase, ovulation regularity, and luteal phase? I would say I can in the clinic because I'm watching numbers, right? And I'm looking at ultrasounds and I can see how robust her hormonal profile is that month. I can see if her ovulation hormone was just barely enough or it was 3 times over what she needed. I can see if her progesterone is, just barely 30, right, which would be considered low, or if she's got a nice, robust endogenous progesterone production. And so this is where we find these hormones so valuable for predicting, cycle regularity. And the hormonal expression is a sort of a profile of that particular cycle's dominant oocyte, right? And so if she's struggling to mature the egg and the ovulation occurs way late into her cycle, we're going to want to treat her lifestyle and treat her follicular phase for sure, because it's a maturation problem of that follicle, right? If she's got low progesterone, you're also going to want to treat it in the follicular phase because the low progesterone is a repercussion of an egg that's struggling to mature. Right? So, I'm not a huge fan. I don't stop and start stuff at different points in my patients' cycles. I don't do that because realistically, if you have a healthy follicle, that comes from treating her before the cycle and during the follicular phase. If we have a low progesterone level, we can treat that with, giving her progesterone, but you want to look back into the preventative side and say, why is it low? Can we treat that? Can we help her egg mature, produce a more robust level of hormone? Yeah.
Right. So always try to uncover the source and fix there instead of just the symptoms.
Exactly. Right. And if we can't fix it, we got an answer, but it's best if you try to understand why it's happening for her. Right.
Yeah.
And in a lot of those cases where she's ovulating later, as in PCOS, and it's more of a follicle or an egg maturation. The follicle won't ovulate until it's mature. And in those folks, they have a fingerprint that is, contributing to the egg having difficulty maturing, right? So it could be an insulin sensitive issue and a weight issue, could be a dietary issue combined with that. It could be an overt hormonal issue, right? She's not producing enough estrogen and she overproduces testosterone. So there's a few different reasons. And that's why I would say I can really see that in the clinic. As of to date, there is no egg quality test.
Okay, interesting.
There isn't one. No.
There is for sperm, right?
There is for sperm. So for sperm, we can do lots of stuff. We can do a semen analysis that will look at the count, which needs to be 20 million per mil to be normal. The motility, which needs to be about 40% motile sperm to be normal. We look at the shape, heads, bodies, tails, the morphology, that needs to be about 4% to be normal. And then we can sort of a more in-depth test on the sperm called a DNA fragmentation test, because you can certainly have normal parameters that have a high DNA fragmentation, and those will result in pregnancy rates, lower fertilization rate. But if you can identify any of those factors, count, motility, morphology, or DNA frag, you can treat it, right? And so that's part of why we developed that at-home sperm test and brought it out, because the hardest part sometimes to uncovering male factor is getting them into the clinic to do the test. Right? It's uncomfortable. So I say to the patients, I'm like, well, I got a test for you then. It's so great. It's an interesting Saturday night activity, and you can, produce a sample at home. You put it into this apparatus that's uploaded to an app. And once they get your information, within 20 minutes, you get semen analysis that shows your count and motility and a video of your own swimming sperm sent to your phone. It's wild. And so, I can't say how many people have used that test and it's been flagged as abnormal. And that was the problem the whole time. Meanwhile, yeah.
But you can't do that for women, because I guess you could extract an egg and test it, but that wouldn't mean anything for the next one, or?
So for women, the flag here would be the FSH test and the AMH test. So these are hormonal tests, and FSH will be high, right? So we're coming out with an at-home FSH test that if her test is over 10, she should see a doctor, right? Period. Right? Because it shouldn't really be over 10 on day 3 of her cycle. We usually do our hormone testing between day 3 and day 5. And so if it's over 10 at that point in time, flag straight to the doctor, right? Do not wait. Doesn't matter if you're 27 or 37.
Sorry, FSH is follicular stimulating hormone.
That's right. FSH, follicular stimulating hormone. It comes from your pituitary gland. And it is basically the sort of instruction system to your ovaries of how start producing follicles. And if it's elevated, it shows us that the ovaries aren't really responding, right?
That's often in PCOS, right?
Well, no, I would say that usually the FSH is low in PCO and the LH is high.
Oh, okay.
Yeah, LH is the luteinizing hormone, which is your ovulatory hormone. Usually only spikes once a month when the egg's mature and gets ready to go. But in PCO or PCOS patients, oftentimes you'll see a flipped ratio where the FSH is a bit lower because they have a ton of follicles. They already have a ton of follicles, and the LH is higher. So it's a maturation problem typically with their follicles.
Okay. But in your previous answer, you also kind of busted another myth that PCOS women do not ovulate. They do ovulate often, but late in the cycle.
Yeah, so I would say there's probably 3 separate classifications of PCOS. So there's the Rotterdam classification, PCOS, polycystic ovarian syndrome. She doesn't ovulate, or she ovulates very irregularly. Okay. Often, not always, often this is combined with potentially high BMI and difficulty maintaining a normal weight. Often her insulin is elevated, and those two are related. Often she potentially has acne, especially cystic acne that would come along her jawline, her chest, or her back. So it's distributed in a specific area. And sometimes she would see male pattern hair thinning right up here. And that's a repercussion of higher end testosterone or androgens. So that's one classification. That's your classic. And then you have what we call oligo-ovulatory PCO, meaning that she ovulates, but it takes a long time. like it's really irregular and it takes a long time. Maybe she gets a cycle once every 2 months or once every 45 to 50 days, that kind of thing. Um, and those can vary heavily on lifestyle factors for sure. Okay. With her, everything else might be normal, right?
Right.
We can tell, right? She just has oligo-ovulation. Usually she's the one that has the high LH. Um, and the trick for her is that the ovulation is so irregular, it's very tricky to time conception.
Okay.
Right. And then the other classification, I would call them lean PCO patients or lean polycystic ovary patients. They may not really have symptoms, right? They just tend to be kind of lower end BMI. She tends to be really prone to being hangry. So she's got kind of hypoglycemia presentation of the glucose disruption. And she's usually normal or lean weighted. And then when you go do ultrasound on her, she's got a ton of follicles, like a ton. And so when we do ultrasounds as part of the fertility assessment, when we visualize each ovary, we would count how many follicles are showing up on her day 3 to day 5 as part of our fertility assessment. And that's called an antral follicle count, or AFC. So if the follicle count is over 12 on either side, it's automatically tagged as being polycystic ovaries. And further, the report will say further hormonal investigation recommended, right? So test her hormones to see if they're normal. She might just have a lot of eggs. And then the last myth I'd bust, I guess, is that you can have PCO and you can have PCOS without having cysts. We always say cysts. We say cysts happen. They come, they go. Sometimes we catch them on ultrasound. Sometimes they're repetitive. We can treat them and help them have less a significant recurrence, right? And we can reduce their size. But you're not always, you can have polycystic ovaries or polycystic ovarian syndrome without necessarily having a constant ovarian cyst, right? They're more prone to it, but they might not always see it on ultrasound.
Yeah. And those conditions, can they be treated or just managed?
I would say it's in her fingerprint, all three of those conditions, in a sense. So one of them has a real prone to testosterone and insulin swing production, the PCOS Rotterdam patients. Others in there might be more sensitive to stress and more sensitive to glucose disruption. Women that have PCO and PCOS usually have first or second degree relatives that have history of glucose utilization problems like diabetes, either type 1 or type 2, or maybe they have a fairly strong family trend of cardiovascular conditions, right? So MIs, hypertension, obesity, all of that kind of stuff. So in a sense, when I spy it in her reproductive workup, I say, okay, who in your family has diabetes, or who is there anybody prone to hypertension or high cholesterol early? And you can learn a lot of information by knowing her family history. Yeah, because she's vulnerable to that.
Awesome.
Yeah.
So I think we're kind of like running out of time already, but so for the end, I just wanted to talk a little bit about what do you think, what in your opinion is the future of fertility care in women in terms of medicine, pharmaceuticals, supplements, technology, all the available tools that are out there? How are we going about utilizing them to help women on their fertility journey, I guess?
Yeah, that's a great question. I think that the future of big changes in fertility is going to be a few different things. First, I think that you're going to see a huge trend in female wearables. You're going to see more close to the patient ability to track hormones and biorhythms that would indicate hormonal function in an individual patient more frequently, more easily, more accessible. I'm kind of obsessed with this. I love biofeedback. I love sports medicine, actually, and there's a lot of overlap between sports medicine and fertility because it's really all about mitochondrial health. And so I think that we're going to see a lot of wearables for everything from heart rate variability.
Like IV.
Yeah, IV. And then I've also heard of some cool innovation coming up where they're able to track urinary hormone output over a month period of time with a very fresh device. But I do think female wearables are going to be huge because it gives us data, and you can't change what you don't measure. So I think for a long time, we've been just like not measuring. And so I think that that's very valuable. I think you're going to see a lot of change in wearables that will be able to give you blood tests, right? And your variability of insulin and metabolic markers, right? So I would consider the metabolic markers are the ones that dramatically influence egg quality, right?
So something like diabetic patients already use now on daily basis.
Yeah, that's right. But just maybe looking at it slightly more in depth, slightly more from a reproductive lens, for sure. Yes. I think you're going to see a lot of change with genetics. Again, it's another area where I'm ultra obsessed. I think you're going to see change in individual genomics, combination genomics within embryo testing. And I think we're going to get more refined at utilizing the information. And how are we going to do that? By using AI technology, right? In order to help us filter the data. So those would be my three. I think wearables, genetics, and AI/algorithm influence into medicine to help us really spin on the big data collection that we're seeing now from the genetics and other tests that we have.
Awesome.
And egg freezing. I think that's the other big one that's like on the table that the ladies really need to know about, because we're having our babies later.
Yeah.
We spend our most of our reproductive career in school, a lot of times doing other things. And so I think it's super empowering for her to know her fertility potential and know that if she's not ready, freeze your eggs.
Yeah.
Freeze your eggs.
It's kind of like a taboo, right? Talking about it. It's still kind of like a taboo, freezing eggs for women. A lot of women don't want to really consider it. Or we think, no, I'm going to do it next year. You know, I'm going to have babies next year. And then you're 35, I guess.
And you're in my clinic. And, you know, I think they call it, the technical term is oocyte cryopreservation. Okay. Or, you know, to the public, it would be egg freezing. Right. And if she's not ready to have her babies before 35 and she's got a big career and she hasn't, you know, met her match yet, then I think it's incredibly empowering for her to be able to, engage in treatment that would cryopreserve eggs when she's young. And, you know, to infer on that a little bit further, there's some really cool technology that we can utilize now. There's an AI tool that we can utilize to tell her of the eggs that we retrieved, how many of those will result in a live pregnancy. And so this is really different. It used to be like, oh, great, we'll retrieve 10 eggs and you retrieve 10 eggs. Is that enough, do you think? And she would really have no context because she wouldn't know how many are viable. With its Future Fertility's Violet test, it's an AI algorithm that they're looking at different aspects of the eggs, and they're able to predict with very significant accuracy how many of those 10 eggs could result in a pregnancy. And when she has context, it'll change her choices. Do I have enough? Oh, only 2 of those will result in pregnancy, but I want 3 kids. I better do 1 more retrieval.
Right.
Right.
Maybe
And that's something.
Maybe this question is a little bit out of your professional kind of scope, but I guess you can answer it from your personal perspective. Isn't it kind of also a little bit unfair to women that we have to discuss so much about using technology to preserve our fertility instead of, having a chance of having babies early, or, having babies in our 20s when we're meant to be 20s? I feel like women are often not supported enough, not given chances to have that life, right? To have both, to have babies and career.
Well, it's I would say it became out of vogue to have babies early because she wanted a career.
Mm-hmm.
And so if to initiate your career when you have an infant on your hip is potentially a lot more difficult.
Yeah.
But maybe that's short-sighted.
Yeah.
Because what else is difficult? IVF.
Mm-hmm.
Yeah. And, missing an opportunity. And so,
Right.
it's tricky.
Yeah.
There's very few 20-year-olds that I know of that would sign themselves up for pregnancy,
Yeah.
between 20 and 27, let's say. I don't know very many of them. I actually get excited when I see them because I'm like, "Ooh, you're doing it at just the right time. Perfect."
Right.
Yeah. So
I feel there's a lot of misconception with in our 20s. I also thought it's really hard to have a baby and start a career, but it doesn't really get easier because now my career is basically peaking, and now I have a 5-month-old, and it's even harder. I think it's
how
even
tired
harder.
are you, Urška?
Yeah, it's
Tired, right?
hard.
And so I think this is an incredibly important point to just pause for a second on. Our generation is really only the 3rd generation in history of women who are having babies and working outside the home in a full-time capacity.
Mm-hmm.
And so, we're even if you have an incredibly supportive partner, and in the early days of babies, it's a very female-centric thing. You're carrying the baby, you're having the baby, you're breastfeeding the baby potentially, for the first few years. And this is where they would estimate a female as doing, the equivalent of 3 full-time jobs if she's has young kids and also a career. And then what type of repercussion does that have on her health? And you believe me, I am a feminist, but at whose cost? Oh, make no mistake, it's at our cost, right?
Yeah.
Because the expectations on us are still there. So I think that framework potentially needs to be rewritten a little bit in the expectations of ourselves and societal expectations of us, because we're still kind of new at doing it all, right?
Yeah, true, very true. I agree with that.
Yeah. So take your supplements, Urška. Take your supplements. Don't stop because you had the baby. So this would be a take home. I would say any women who just had a brand new baby and she's got a full-time job and she thinks she might have another one, just continue on with those supplements because it will help you build back, yourself to the point where you're strong and healthy to potentially enter another pregnancy, right?
I know, but in all insanity, like the supplements are the easiest ones to forget after the whole day.
I know.
I'm happy if I get one full meal in a day. So supplements are, at the end of the day, just like nice to have. But I totally agree. And this ties in so well with the last question that I wanted to, or like almost the last question that I wanted to ask you. And that's, what are your top 3 recommendations to our listeners to start doing and 3 to stop doing if they want to, take care of their fertility health or, health in general?
Yeah. So I would say top 3 starts would be eat healthy food and eat real food. Number 1. I got 4 actually. Number 2 would be please sleep, because it is the seat of health. And if you can't see somebody, because you got to find a way. 3 would be exercise. You have to move your body. It's the only vehicle you have to drive you through life. And females start losing muscle mass at 30. So the PSA that didn't go out is that all women in their 30s need to eat enough protein and weight lift. Everybody.
Amazing.
Right? Yeah. And the 4th one is to support that whole circus show that we have going on. Take a prenatal vitamin during your 20s and 30s so that you can, supplement your nutritional deficits and certain nutrients that are key to your fertility that you might not be getting good doses of on the daily. And while you're at it, you might as well take one that has been thoughtfully formulated to address potential genetic factors that would also contribute to egg quality issues, right? And so the don'ts would be, don't smoke. Just don't smoke, right? That's so 1970s. Like, we're over that now. So we shouldn't smoke, if I could. The other thing, and I don't mean to be like a downer, so I'll put this in the same bracket, is alcohol has become a social drug that is celebrated in women. It will train wreck your hormones and oxidative stress patterning faster than anything else, right? It's like increased risks of multiple cancers. It trashes your sleep. I could go on and on and on about that one. You have to don't prioritize your job over your self-care. Don't do that. Do not do that, right?
Yeah.
Don't do that. Like, there'll be a day or two where you might need to, but then you have to look at your self-care routine and say, okay, what are we doing like that so this doesn't happen again? You have to learn to say no and have healthy boundaries and not feel guilty about it. That'll be my second. And let's see, my third don't. I would say, don't. I got a real problem with ultra processed beige carbs. I think we got white bread problems here in North America.
Very specific.
like significant. I think that if we just got rid of the beige carbs, it would solve like 50% of our dietary problems, right? And I think if I could insert one last don't compare yourself to other successful women. Use them as an ideal to lift each other up. The whole social media comparison is the thief of joy, and I think that there's so many women out there that are doing fantastic things. I just want to make sure that they're not so tired. Everyone's very tired, right? Because we're overexerting ourselves. And so I'm like a bit of the nutrition police, a bit of the supplement police, and a bit of the sleep police, I would say, in the clinic for sure.
Amazing. Thank you so much. These were really valuable. But then also, if our listeners want to expand in terms of knowledge on those topics, what literature, or do you have any literature to recommend to our listeners?
Yeah, you can go. I mean, definitely Bird and Bee has a fantastic blog series that's been produced called The Nest. And we really do address lots of topics. And it's interesting there because we have medical personnel that are from conventional medicine, like reproductive endocrinologists. And then we have naturopathic doctors that are interfacing on the same topic. So I think you get a really balanced approach. We also have a lot of educational material on conceivehealth.com. Conceive Health is my clinical practice. So we now have, it started with 2 NDs, myself and Dr. Fitzgerald, and now we have 17 NDs. And so those doctors, those female doctors are so smart, and they're always putting out amazing content on our channels.
That's incredible.
Yeah.
Thank you so much. Thank you so much for coming on to our podcast to talk about fertility health, PCOS, the future of fertility care in women, recommendations for our listeners. I think this conversation was so rich in information and advice and guidance. I just feel so grateful to have this conversation with you. Thank you so much, Dr. Tracy.
Yeah, thank you so much for having me, Urška. I appreciate the opportunity.
Thank you. All right. And goodbye to our listeners. You can tune in on all major podcast platforms, follow our IG channel, YouTube channel, and also join our Facebook group called Bellabeat Club, where you can also join challenges and compete for Bellabeat products, which is always a fun thing to do. Like Dr. Tracy mentioned, wearables for women are the future of healthcare.
Definitely think so, for sure. I can't wait to see what comes of all that data.
Awesome. Thank you so much, Dr. Tracy, and goodbye.